Assalamu alaikum. Today, inshallah, we will start case number 3, fourth nerve palsy with botulinum toxin trial. Yes, Dr. Khadija, can you please start reading?
A 67-year-old man presents for evaluation of diplopia. For the past year, he has noted binocular vertical diplopia worse in the right gaze and up gaze. Neuroimaging, including an MRI of the brain with an MRA, has been performed elsewhere and were normal by report. Examination. Visual acuity without correction
Before
in the
examination,
right is 20/20.
his outside ophthalmologist has prescribed.
Oh,
uh,
I'm sorry.
yes.
His outside ophthalmologist has prescribed prism glasses, but these did not provide relief of his symptoms. He finds that his symptoms have been worsening, and although he has not been symptomatic with reading, he is concerned that he might fall because of his diplopia.
Okay, just here,
Examination.
two points before we go to examination. See, he said about past year, and he has binocular vertical diplopia. So he talk about something related to vertical or vertical muscles, and worse in right gaze and in up gaze. And we will talk about detail what is meaning of worse in right gaze or worse in left gaze. Always fourth nerve palsy worse in the opposite gaze and better in the opposite head tilt. Okay, continue, Dr. Khadija. Later on, we will make the discussion.
Visual acuity without correction in the right is 20/20, and the left is also 20/20. External examination. Right head tilt with mild chin up position. There is also mild facial asymmetry with left side larger. Sensoromotor evaluation. Motility in the right shows +1 downwards and temporal, +1 to 2 in the left eye upwards and temporal, and -0.5 downwards and temporal. 1 to 2 plus inferior oblique overaction with subtle superior oblique underaction on the left. Otherwise, ductions and versions were full.
Continue.
Deviations for distance uncorrected is left hypertropia, right, sir?
Yes, you're right. Continue.
Left hypertropia 6, and the near uncorrected is exotropia 8 and left hypertropia 5. The diagram, sir, you'll have to help me with.
Yes, so
I can
here,
help. I can help.
yes, please, Dr. Muhammad.
And in the primary position here, we see left hypertropia 6. This left hypertropia increased in right gaze to 12. But this hypertropia in left gaze decreased to, to be 8. In the up gaze, the left hypertropia 10, and in the down gaze, the left hypertropia 4.
Yes.
Okay.
And
But
in the head tilt?
In the head tilt, left hypertropia decreased to 4, and in the in the left head tilt, increased to 14. So we have left hypertropia increase in the right gaze and increase in the left head tilt.
Yes, decrease in the right head tilt here in the head tilt and increase in the left head tilt. I hope it's clear here. Okay. Yes, Dr. Khadija, continue.
Double maddox rod. In the right is 2 degree cyclotorsion, and in the left is 7 degree cyclotorsion. Net 9 degree X cyclotorsion. Vertical fusional amplitudes, able to see singly up to 25 prism diopter base up prism over the left eye.
Okay, here in the pictures, in a primary position, I think there is here mild left hypertropia. And when he look to the left and up, you can see here the inferior oblique overaction in the left eye, especially here they mention it. And the right eye, sorry, in the left eye, when he look down and inside toward his nose, you would see here limitation in his superior oblique action. And in the left gaze here, sorry, in the right eye, you can see it, sorry, it's here. Here you can see overaction of the superior oblique, sorry, in this here, okay? You can see here the superior oblique overaction +1. I hope it's clear here to clear in the
Okay.
pictures. Yes,
Dr.
Dr. Muhammad.
Abdurrahman, we have
Yes.
many important points inside this case. The first one, facial asymmetry, which mentioned inside the history of this patient. Facial asymmetry, yes. Facial asymmetry that decreased. The facial asymmetry should be discussed vertically, not horizontally here.
Mhm.
Vertically, making the nose right and left.
You want me to make horizontal line at the pupil margin?
No.
Ah,
Vertical line passing through the nose, yes.
okay.
Right to this line is a smaller one, smaller field. We don't need horizontal line, just
Yes.
vertical line.
Okay. I'll try my best. Yes, continue, please.
ماشي. Again, the right field here, the right field for the patient, I mean, is smaller than the left field because right head tilt. This sign mostly due to congenital form of fourth nerve pulse or congenital form of vertical palsy, vertical torsional muscle palsy. So here we have a right smaller field and the left wider field. This is the first sign inside this case. The another one is hypertropia, which mentioned previously, left hypertropia, which increased in the right gaze and increased in the left head tilt. The third important point here is a vertical fusional amplitude. Anyone tell us about the normal vertical fusion amplitude? Can anyone tell us? Okay, the vertical fusion amplitude, it's near 2 to 3 prism diopter, which if any normal patient have vertical displacement or vertical misalignment, 2 to 3 prism diopter, he can diffuse the image and can tolerate any diplopia. But furthermore, cannot. But in congenital form of fourth nerve palsy, the patient mostly will, the fusional vertical amplitude should be very high, sometimes reach 25 to 30 prism diopter. But the cut point here is above 10 prism diopter.
Mhm.
This is the clue to be sure this is form, it's a congenital form, not an acquired form. We will discuss further inside the case, inshallah.
Here you think it's congenital in this case?
Yes, because many think facial asymmetry. The other thing is fusional vertical amplitude 25 here.
Yes, he mentioned
Actually, one
it's
clarification, doctor, you were telling about congenital and acquired, no? So how do you differentiate congenital and acquired? Do we have the compensatory head position and the decompensatory head position, no? So which is the one which comes? We're just trying to recall. A compensatory head position will be seen in congenital or acquired?
No, head tilt, it's in congenital and acquired. It's a maneuver. It's a maneuver to compensate a torsional diplopia. but
Hmm.
you can differentiate between acquired and decompensated congenital fourth nerve palsy by many tips. One of the tips, old fetus. The other tip, it's a facial asymmetry. Another tip also is a fusional amplitude should be very high, but in
Yeah,
acquired
as
form,
you said, the vertical fusion amplitude will be 2 to 3 is the normal range. So if it
yes,
goes out of that boundary, if it goes more than that, then that will be a kind of confirming, right? That will confirm that your what to say, your this thing is the Fortner pulse is like more evident.
yes,
It becomes decompensated, right?
yes, 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 right.
Yes, yes.
Okay.
Let us continue. Maybe we can discuss after we read the case. Yes, Dr. Khadija, please continue.
Dilated fundus examination, 2 plus X cyclotorsion both eyes. Dr. Sistari's assessment plan. This patient had symptomatic left fourth nerve palsy given the findings of a left hypertropia, worse in the right case, and left head tilt, as well as a total of 9 to 10 degrees X cyclotorsion on double maddox rod. Given the large vertical fusional amplitudes of 25 prism diopters and mild facial asymmetry with the affected side larger, the etiology is most likely a decompensated congenital left fourth nerve palsy. His hypertropia is larger in up case and down case, causing him to be less symptomatic when looking down. This is atypical because many patients with a fourth nerve palsy are more symptomatic when looking down, because the secondary action of the superior oblique muscle is depression. When approaching the treatment of a patient with fourth nerve palsy, the surgeon needs to consider two key factors: whether the etiology is congenital or acquired, and the degree of accompanying torsion. Establishing whether the palsy is congenital or acquired influences the treatment approach that I use. I have found that even when there is a deviation in primary position, patients with a congenital fourth nerve palsy can often achieve single vision using a base down prism in front of the hypertropic eye, with a power that is much less than the total measured deviation because these patients have such large vertical fusional amplitude. And I use this information to help guide surgical planning because it determines the minimum amount of surgical correction that I need to perform in order to alleviate the diplopia. For example, if a patient has 10 prism diopter hypertropia in primary position from the decompensation of a congenital fourth nerve palsy, and he can achieve single vision when a 4 prism diopter base down prism is placed in front of the hypertropic eye, then I may simply perform a unilateral inferior oblique myectomy to decrease the hyperopia from 10 prism diopters to approximately 6 prism diopters and let the patient fuse the residual 4 prism diopters. However, if the same patient has a 10 prism diopter hypertropia from an acquired fourth nerve palsy and has a typical vertical fusional amplitude of 2 to 3 prism diopters, I will plan on essentially correcting the entire vertical deviation surgically. Since an inferior oblique myectomy typically only corrects approximately 3 prism diopter to 5 prism diopter of hyperopia in primary position, additional surgery would be needed.
Okay, before you
Secondly,
continue, let us just make some note. Before, in the first of the paragraph, he mentioned about he have total 9 to 10 excyclotorsion in double maddox rod. So let me just tell you a little bit about double maddox rod before we continue, so you understand what we are talking about. So first of all, double maddox rod, you should know this is a series of cylindrical lenses. And here this is the lens. So this is rods, okay. They put here red one, and in the other eye they put it like white one, or they put it both of them red. This is, we call it the double maddox rod test. So what is the effect of this rods? So when there is a source of light passing through this cylindrical lenses, will make a line 90 degrees away from the axis of the cylindrical lens. And this is always how we correct the astigmatism. So when we have like in this case, like we have like right hypertropia, so you bring a light and this light you just direct it toward this lenses. So it will give you two lines. Okay, you make it vertical. This lenses you make it in a vertical way. Okay, so it will give you two line, and these two line are separated from each together. Red one and the other one is the light white one. So when they are separated from each other, like in this case here, this is the red line, and here this is the white source, or especially if there is on the both eye, there is two lenses. So here we have hypertropia. The two lines are separated from each other. Okay, and also you can check the torsion. How you check the torsion? You will see one line is straight and the other line is tilted. And we can make the other line parallel by moving this maddox rod. Okay, you can just tilt it, tilt the degree, so you can know how much is tilted. So when you rotate this maddox rod, let me show maybe another picture like this one. I think it's clear. Yes, here. So here you can see the degree at this area, and here you can see it's in the vertical picture. Okay, so when you rotate the maddox rod toward the nose, okay, you measure the encyclotorsion. Okay, so when you rotate it toward the nose, always you measure the encyclotorsion. But when you rotate it temporally, you measure the excyclotorsion. Okay, these are two important points I want you to know about maddox rod. So it will give you like a hint or help you how much the encyclotorsion and how much the excyclotorsion. Look here, they are parallel. You still move this maddox rod and until they become the two lines are parallel, and this is the degree of encyclotorsion or excyclotorsion. Here still tilted, so there is torsional effect. You keep rotated it until the patient see, you tell the patient and keep rotate it until both lines become parallel to each other. Okay, this is how you measure how much the encyclotorsion or excyclotorsion. Because if you notice here, they said when we start reading, they said there is +2 excyclotorsion in the right eye, there is 7 excyclotorsion in the left eye, and the total are 9 excyclotorsion. How they measure the excyclotortion? By maddox rod, by double maddox rod. And I hope it's clear now after you see the picture. The second point, actually, I want to ask you, Dr. Muhammad, here they talk about very important hints or tips about, he said, I will go for myectomy, I will not go for like other procedure according to the measuring to the angle. Can you please clarify this point, please, from your experience, Dr. Muhammad?
Yes. Again, we should differentiate between acquired form and congenital form of fourth nerve palsy because of the plan will be different. In the congenital form, we have a very large effusion amplitude. So the minimum effect of an inferior oblique myectomy here will give us like 5 prism diopter in vertical misalignment and also 5 prism 5 degree of excyclotorsion correction. So here it's a good for congenital form. But if this patient the fourth nerve palsy because of the acquired form, it's not sufficient to do inferior oblique myectomy here. It will not correct every misalignment here in vertical displacement of misalignment and also the excyclotorsion. So it should also another form of inferior oblique weakening like recession, graded recession or anteriorization. Or you can also add another muscle to inferior oblique here.
Thank you so much. So when it's like here, because he said mention like you said 5 degree excyclotorsion and about 5 like the vertical fusion about 5 prism diopter, inferior oblique myectomy can correct 5 degree about this vertical fusion and 5 degree of excyclotorsion. But if it's more than that, the inferior oblique myectomy alone, it's not enough. We need another procedure on the inferior oblique or work in inferior oblique and another muscle in the other eye, vertical muscle, like inferior rectus. Okay,
Yes.
we will discuss more maybe about the surgical plan. Yes, Dr. Khadija, can you continue, please?
Secondly, I want to know how much excyclotorsion is present. Since patients can fuse up to 8 degrees excyclotorsion given time to adapt, many patients with fourth nerve palsies can be treated with prism therapy alone. While a prism can alleviate vertical or horizontal diplopia, it cannot alleviate the symptoms of torsion. If a patient with fourth nerve palsy, whether it is congenital or acquired, is unable to achieve single vision with a prism, it may be because torsion is an impediment to fusion with a procedure that improves torsion. Needs to be part of any surgical plan. An inferior oblique myectomy will correct up to approximately 5 degrees excyclotorsion in acquired palsies and sometimes more in congenital cases. In this case, the patient has 6 prism diopters left hypertrophia in primary position that increases to 12 prism diopters in right case. He is not able to achieve single vision with the prism, and this is due to the 9 degrees to 10 degrees excyclotorsion. Based on this finding, he definitely needs an inferior oblique myectomy. This will eliminate at least 5 degrees excyclotorsion and approximately 3 prism diopters to 5 prism diopters of left hypertropia in primary gaze. However, the hypertropia increases to 12 prism diopters in right gaze and 14 prism diopters in the left head tilt. Given these findings, I must decide if a right inferior rectus resection must also be performed in order to provide a larger area of single vision.
Recession,
Since I am
right? Inferior rectus recession. Yes. Yes.
Sorry, right inferior rectus recession must also be performed in order to provide a larger area of single vision. Since I am not able to determine this with a prism trial, I will inject the left inferior oblique muscle with 5 international units of botulinum toxin A, Botox, to mimic the effects of an inferior oblique myectomy. If this treatment completely eliminates the patient's symptoms, then I will proceed with just an inferior oblique myectomy. If the symptoms do not resolve, I will add a right inferior rectus recession to the surgical plan.
So here he think about the other eye procedure. He has left eye hypertropia, and the right eye it's hypotropia. So because it's hypotropia, he will go for right eye inferior rectus recession to weakening the inferior rectus to make the eye a little bit up in a simple way. Dr. Muhammad, do you want to add anything here about his assessment and plan before we go to the surgery?
No, but actually in our practice, we don't use Botox. Another thing, Botox is prescribed also in rectus muscle, not in oblique muscle. This is in our practice.
Actually, I work now with a
Any particular,
surgeon.
sorry to interrupt, any particular reason why you said that Botox is preferable in rectus and not in oblique? Is it for any particular reason, for cosmetic thing or like, why do you say that, doctor?
Yes, Dr. Muhammad, he asked you, Dr.
I'm asking Dr.
Samuel,
Muhammad, yeah.
why always you go
As you said,
for...
it's from experience. It's an interesting point that you...
Again, Dr. Abdurrahman, why what?
He asked you why you go for Botox for horizontal muscle, not for oblique muscle. And even I work now with a surgeon, he preferred to do Botox even for oblique. I saw him, he inject in the inferior oblique more than one case. So why you didn't like to go for oblique?
Because obliques muscle is mainly action for them is an intorsion and excyclotorsion. And you know, the encyclotorsion and cyclotorsion, if impaired, sometimes you cannot correct it. You cannot correct it by prism, by prism adapting glasses.
Yeah, because
So,
even through discussion, we saw that that is the excycler rotation only to an extent of 5 prism diapers, right? If I'm right, can only be corrected. So more than that will not be corrected. So to the extent of 5 prisms only can be corrected. But even rectors can also correct excycler rotation. They also cause like superrectors, and it will be the tertiary action of superrectors and inferior rectors.
Yes,
you
but
know, the
it's very minimal.
superior rectus and inferior rectus mainly is elevator and depressor of the eye. The tertiary action for them is an encyclotorsion and excyclotorsion, but it's not a main
Yes.
and primary action
Yeah.
for superior rectus and inferior rectus.
Okay.
Oh,
Yeah.
okay.
Okay.
Thank you.
Okay.
Thank you, Dr. Muhammad. Yes, Dr. Khadija, surgery, please.
Surgery. Surgery 1. Botox injection left inferior oblique muscle 5 units. Interim visit. The patient reported that 1 week following the Botox injection, his diplopia had completely abated. This effect lasted for approximately 2.5 months, but by the time he returned for a follow up visit 4 months later, the measurements had essentially returned to their pre injection state, and the planned inferior oblique myectomy was scheduled.
Nice. Continue.
Surgery 2. Left inferior oblique myectomy. Follow up. At the most recent follow up, 4 visits following surgery, the patient was pleased to report that he had no diplopia at distance or near in any direction of gaze, including right up gaze. Visual acuity without correction in the right is 20/20 and in the left is 20/20. External, no apparent anomalous head position was noted. Sensoromotor evaluation, motility, ductions and versions were full.
So here, the post-operative motility, full gaze, up and right, not available, they said. Okay, Dr. Muhammad, do you want to make any comment at this picture post-op?
Here we see in the primary position ortho. I cannot determine if there is an misalignment vertically in the right gaze and left gaze. I see like ortho also in the right gaze and left gaze.
They said there
Uh,
is exotropia, I think, mild 6-degree exotropia.
no, this is at near these photos at
Yes,
distance.
okay,
Here also in the up gaze and down gaze, I see everything is okay.
okay. Okay, continue, Dr. Khadija.
Review lessons learned. A fourth nerve palsy is generally characterized by binocular oblique diplopia, worse in the field of contralateral gaze and ipsilateral head tilt. There may be excyclotorsion of the affected eye, which may be elicted by double maddox rod testing and may be apparent on a dilated fundus examination. The
Before
etiology
before you continue, sorry for interrupted, always in the exam, because they will bring a picture and you will see like left hypertropia or right hypertropia, and they will ask you what is the next, and they will ask you about do 3-step test for this patient. If it's a clinical or if it's OSCE, they will ask you what is the 3-step. So always remember WOG and boot, and this is just an exam. I use it. WOG worse in opposite gaze. So if you see like left hypertropia, okay, left hypertropia in the left eye, and just like right, left, or right gaze, so it will be worse in opposite gaze. Left hypertropia, it will be worse in opposite gaze, right eye, and better in opposite tilt. So it will be better in the right head tilt. Okay, this is for the tilt. So remember, WOG worse in opposite gaze and boot better in opposite tilt. Just here they mention about the retina. You will see if you just make a fundus exam, and you will see the excyclotorsion or you will see the encyclotorsion. Just let us show a fundus exam. Here, Dr. Muhammad, can you make your comment which eye has excyclotorsion or it has a problem from the fundus exam? How we can know here?
Okay, you should know this is the real image or inverted image. If you mean this is the real image of the fundus photo, typically the fovea should be down to the optic disc, like in the right eye. Yes.
Yes. Okay. Here it's
Excyclo
not the real image. Always it's the opposite, inverted image here. Yes, in left eye.
in the left eye. Uh, uh, Suppose this is the real image. The excyclotorsion will appear like fovea down to the optic disc. So this is the excyclotorsion of the fundus.
Yes, so you will see it downward related to the optic disc. So here you can also know this is excyclotorted eye. Okay.
For my experience, in the indirect ophthalmoscope, you will see the fovea above the optic disc. So if you see the fovea is in excyclotorsion above the optic disc very high, to memorize it, excyclotorsion exaggerated.
Yes,
Excyclotorsion
this is
exaggerated.
indirect ophthalmoscope, but in
Yes.
direct ophthalmoscope you will see it downward, like this picture here.
Here it's a fundus photo.
Yes, sorry, fundus photo. Okay.
Oh.
Yes, so let us continue. This is for the fundus exam. Okay, continue. Khadija, please.
The etiologies may include congenital, traumatic, ischemic, or compressive. A brainstem lesion causing skew deviation may mimic elements of a fourth nerve palsy. See case 35 for an example of skew deviation. Further, questioning about a lifelong health tit and or a review of old photographs can often confirm the congenital nature of the misalignment. Facial asymmetry is also consistent with a congenital superior oblique weakness, with the weak superior oblique muscle on the large side of the face. In this case, the vertical fusional amplitudes exceeded that which would be expected in an acquired fourth nerve palsy, which has amplitudes of less than 4 prism diopters, which provided support for a congenital etiology. Furthermore, the normal neuroimaging excluded several of the etiologies described above. Botox exerts its effects by irreversibly inhibiting acetylcholine release at the nerve terminal, resulting in a blockage of muscles contraction. When used to treat strabismus, it is most commonly injected into the horizontal and inferior rectus muscles, with the superior rectus avoided due to inevitable ptosis that would result. Bagheri and colleagues published a technique for injecting Botox into
Doctor,
the inferior oblique muscle. They successfully
Dr. Khadija, I think your connection is unstable. Let me continue from this point. Is my voice clear, Dr. Muhammad?
Yes, yes.
Okay,
Yeah.
sorry for interrupted, Dr. Khadija. Okay, the last 2 points, he talked again about the degree about of the vertical fusion, and here he said would be expected in an acquired fourth nerve palsy amplitude more than 4, which provided support for congenital etiology. So always, Dr. Muhammad, congenital, we have large vertical fusion. It will reach more than 4 here, as they mentioned.
Sometimes reach 25 to 30.
Okay.
It's above normal.
Yes. Let me continue from here. The Botox. Okay. So the Botox exert its effect by irreversibly inhibiting the acetylcholine release at the nerve terminal, resulting in a blockage of muscle contraction when used to treat strabismus. It's most commonly injected into the horizontal and inferior rectus muscles, with the superior rectus muscle avoided due to the inevitable ptosis that would result. Bigari and colleagues published a technique for injecting Botox into the inferior oblique muscle, and they successfully treated 16 patients, most of whom had traumatic fourth nerve pulses, to alleviate symptoms while waiting for the nerve palsy to resolve. Treatment goals of a congenital fourth nerve palsy differ from an acquired fourth nerve palsy. In cases where a patient has a congenital fourth nerve palsy, treatment can often be directed at improving the vertical deviation, the minimal amount needed in order to allow for the large fusional amplitudes to correct the remaining deviation. This may be determined by a prism trial in the office to find the minimum amount of base down prism over the hypertrophic eye that is necessary to alleviate the symptom of diplopia. However, this can lead to a late undercorrection requiring additional surgery if there is further decompensation. The double maddox rod testing can be used to elicit the extent of the torsion. A prism trial in the office may then be useful in determining whether the symptoms of diplopia are secondary to the vertical misalignment or the torsional component. When the prism doesn't completely eliminate the diplopia, one needs to suspect the impact of torsion for the patient. In such a case, treatment of the inferior oblique muscle is an essential component toward improving diplopia. In borderline cases, a Botox injection to the ipsilateral inferior oblique muscle can mimic the effect of a unilateral inferior oblique myectomy and allow the clinician to determine if this procedure will ultimately eliminate the patient's symptoms of diplopia. Here they talk about again the role of Botox. So here, before he go to the surgery, he want to see the effect if I eliminate the diplopia by Botox and if it's work or not, because the action it will come back after 3 to 4 months of this muscle. So when he saw that Botox is work in a very good way, so after 3 4 months he just go for myectomy for the same patient. This is why he go for Botox first. And another thing he said here in the first of the paragraph, you should differentiate between fourth nerve palsy and skew deviation. We will have a case of skew deviation 35 number, but I will just say some words about skew deviation. Always we have like double image and the diplopia vertical and oblique in skew deviation. And mostly it's not localized or related to muscle or muscle group or any nerve. The cause it's structural and the level at the posterior fossa, like there is a stroke or multiple sclerosis or trauma or anything else. So skew deviation, if you want to diagnose it, we should do not a three-step test. We call it five-step test. After you do the three-step test, you should tell the patient to look in a primary position, then to the right or left gaze, then right and left head tilt. We have a step number 4 and step number 5. So we call it five-step test. Step number 4, we call it, we should use the double maddox rod. Okay. In fourth nerve palsy, you will see ipsilateral excyclotorsion, but in skew deviation, you will not. And step number 5, you should compare the deviation in supine position. In supine position, skew deviation decrease in the hypertropia, but in fourth nerve palsy, it's not decrease. So just this is what is the difference between a three-step test and five-step test to differentiate fourth nerve palsy and skew deviation. Uh, I will continue. Hunter comments now, I think. Dr. Muhammad, do you want to make any comment before I continue?
Okay. I have some comments on skew deviations. Skew deviation you can see it after a neurosurgery, but most cases due to inner ear problem, because it's the skew deviation is due to unbalance between inner ear and the system of the torsion of the eye. So the presentation of the skew deviation in three forms of presentation. The first one, like fourth nerve palsy, suppose the right over left, which increase on the right gaze and in left head tilt, but Here, you will see encyclotorsion rather than excyclotorsion. So here the key point is encyclotorsion, not excyclotorsion in the hypertrophic eye. The other form, like inferior oblique palsy, like right over left, which increase to the left gaze and left head tilt. But but in the hypertrophic eye, you should see the encyclotorsion in inferior oblique palsy. But in the skew deviation, you will see excyclotorsion, not encyclotorsion. The other form of the skew deviation, it's okay, right over left or left over right, but this right over left suppose like 30 prism in the primary position, but when the patient will be in the supine position, the amount of the vertical deviation decreased to half of amount, like 15 prism diopter. So the skew deviation can come to us in the three form of presentations.
Yes, yes, thank you so much. Actually, it's a big topic, and I think we will not cover it today by this presentation. And there is a case number 35. Maybe we will go in more detail about skew deviation. Dr. Khadija, I hope your internet connection is stable. Can you continue, Hunter, comments here, the last paragraph? I think it's not stable. Okay. Dr. Samuel, can you read?
Yeah, sure, doctor. Dr.
Yes.
Hunter's comments. One factor that I consider when deciding whether to supplement an inferior oblique myectomy with a vertical rectus recession is the angle of misalignment opposite the field of action of the superior oblique muscle. In this case, the angle in left gaze and with head tilt right. With this patient, the angle was 8 prism diopters in left gaze, which is on the borderline of what might make me consider weakening a rectus muscle in addition to the inferior oblique muscle. But the angle of only 4 prism diopters in head tilt right suggested that an inferior oblique weakening procedure alone would be sufficient. It was a great idea to confirm this using Botox. Sometimes when the measurements in different gazes do not seem to be typical, strong fusional abilities may be confounding the cover test. And I will repeat the measurements. We can go a little bit down.
Just move your screen, yes.
Okay. In different gazes do not seem to be typical. Strong fusional abilities may be confounding the cover test. And I will repeat the measurements after dissociating the eyes with 30 or more minutes of patching. Okay. My other comment relates to the distinction between congenital versus acquired etiology and how much the surgical plan should be altered as a result. I tend to try to correct the full amount of deviation, no matter what the cause. But I make every effort to avoid overcorrections in patients with long-standing hypertropias because they will be extremely uncomfortable with even the tiniest overcorrection. In this case, the hypertropia in primary position measured only 6 prism diopters, which was well within the reach of an inferior oblique weakening procedure. I do not always perform a myectomy to weaken the inferior oblique muscle. I will often do a recession, especially if clinical overaction of the inferior oblique muscle is fairly minimal. But this patient's symptoms were greatest in the gaze up and right.
Okay, thank you, Dr. Samuel.
Sure.
Dr. Muhammad, do you want to add any comments for the last paragraph, or it's clear?
No, it's different school regarding the weakening procedure of inferior oblique. I am from the school of myectomy.
You go directly for myectomy, not for Botox injection.
No, not recession, not inferior oblique recession. You will see two different schools. Once the first school is about the inferior oblique myectomy, the other school it's about the inferior oblique recession, graded recession.
About the inferior oblique recession, how much it will, or according to the graded of inferior oblique recession, how much it will correct maximum recession?
It depends. It depends about the inferior oblique overaction. If you have inferior oblique overaction +1, it's I think we have a special table for this. It's a Barks table for inferior oblique recession. I don't use it because I am a fan of inferior oblique myectomy.
Okay, but you mean that inferior oblique recession, it will give you more correction of this vertical fusion
For
more
fans
than
of
5,
inferior.
more than 5.
Okay, but
Actually, in the discussion, we saw 6 also is the cutoff, right? 6 prism diopters. So that would also be critical for doing surgical correction, no? 6 prism diopters.
Here he mentioned that he can go for myectomy. It will.
but really in literature, the inferior oblique weakening procedure, it's correct up to 15 prism diopter. 15
Okay,
prism diopter.
15. Yeah,
But
yeah. This is my point.
Yes, but in some literature,
15 is too much, no, doctor? 15?
not too much.
You know,
Especially
myectomy sometimes, Dr. Muhammad, it can just reattach again the muscle after you cut it. Sometimes it reattach, and you can see inferior oblique overaction after some
again,
times. And
Dr.
I
Abdurrahman.
saw sometimes when you just cut the muscle and you did myectomy, sometimes this muscle it reattach again, and you will see the same patient have inferior oblique overaction. I saw 2 cases of inferior oblique overaction after inferior oblique myectomy.
No. It's
It's
not the
very
point.
rare. Yes,
No, Dr. Abdurrahman.
it's not the point here.
Inferior oblique myectomy always will reattach to the sclera, always. But if you have a hypertropia and inferior oblique overaction after inferior oblique myectomy, here mostly due to a missed belly of inferior oblique, which not included, sorry, in the inferior oblique myectomy. So if you have an exploration for inferior oblique, in this case, you will see the missed belly of inferior oblique. So you should
I think
make an myectomy for this in missed belly.
I think one thing we have to consider also, you were talking about reattachment and detachment, no, Dr. Ahmed. I think one thing we have to take caution during surgery is a lost slipped muscle, which is something very dangerous.
No,
Especially
here
in
we
such
didn't
For
talk
inferior
about the
oblique,
slip muscle. Slip muscle not in inferior oblique, mostly slip muscle or lost muscle in medial rectus.
Yeah, but it could also happen in inferior oblique, right?
No, I didn't see
no.
any case in my life.
Inferior oblique originally originated from the medial border of inferior floor, and beside the lacrimal sac, and inserted, in the inferior posterior part of the globe above the macula. Never you will see the missed or slipped inferior oblique because of a lot of Schick ligament and also connection to the inferior
The
rectus.
Vitreous ligaments and all are there. So they
Yes,
will all kind of
yes,
hold on to it. Okay,
yes.
right.
yes.
Okay,
Okay.
let me finish review question, then we will see if there is any question. Name 3 clinical findings that can help distinguish a congenital from an acquired fourth nerve palsy. First of all, lifelong history of head tilt confirmed by a history or review of photograph, facial asymmetry, or vertical fusion amplitude. This is actually very common OSCE question in FRCS Glasgow, in Arabic Board OSCE, also in FCBS OSCE exam. How to differentiate between congenital and fourth nerve palsy? First of all, because this question came in my OSCE exam, I asked the
1 point.
examiner, yes,
Yeah. Sorry, doctor. The 1 point has been missed in this actually. I was just thinking through the whole lecture. A recent onset of diplopia is very much evident in a case of acquired diplopia, whereas the
yes,
diplopia is hardly or is very minimal or very subtle in case of compensatory, that is in the congenital long-standing cases. So I think that has to be taken into consideration, and it becomes very troublesome for the patient. So this kind of recent onset of diplopia and the vertical, especially when patients, when they are reading, when they're reading books, it will be so evident. Suddenly they will see there is a vertical diplopia. So everything will look double when he's reading the book. So when they are doing when you do refractive correction, also doesn't get corrected. Then only then when we do Hirschsprungs, we notice there's actually a vertical squint. So that's
Yes.
probably that is an acquired fourth-nerve palsy, which should not be missed in our clinical practice.
Yes. And another thing, always remember two questions. Ask the patient, did you have diplopia when you're reading a book? And the patient, sometimes he came from the history, just you will know the fourth nerve palsy. He told you during I just go the downstairs, I fell down, doctor. When just I go downstairs, I fell
Exactly.
down. This is very common. You will see it in history. So if he go downstairs and fell down, diplopia during reading. Thank you, Dr. Samuel. So as we said, photograph facial asymmetry, vertical fusion amplitude of more than 4 degree, 4 prism diopter are a clinical finding that support the diagnosis of congenital fourth nerve palsy. What is the mechanism of action of Botox and the extraocular muscle? Botox exerts its effect by irreversibly inhibiting acetylcholine release at the nerve terminal, resulting in a blockage of muscle contraction. What amount of torsional disparity is considered an insurmountable barrier to fusion? Normal adult can fuse 8 degree cyclodisparity using sensory fusion. There is also an element of motor fusion such that in total patients may be able to manage as much as 18 degree cyclodisparity. I think it's very large number here. I'm not sure about it. Dr. Muhammad, do you want to make any comment or add anything else? We finished the case here.
No, fine.
It's clear.
But I have a question to audience. I
Yes.
have one. If you have a patient with fourth nerve palsy, but the main concern here, it's not a vertical misalignment. It's a vertical misalignment here, it's a 4 prism diopter. But cyclotorsion here, it's more than 20 degree. The best choice of a treatment here, anyone know?
Yes, Dr. Samuel, what did you think? Did you hear the question, Samuel?
Sorry, tell me, doctor.
Again, a fourth nerve palsy. The vertical misalignment here is a 4 prism diopter, but the excyclotorsion very high. It's more than a 20 degree of excyclotorsion.
Okay.
So the best choice here in treatment. Anyone know?
What about inferior oblique, the surgery? Inferior oblique myectomy. I mean, you said 20 is very high, no?
Actually, I will go with anteriorization, maybe, Dr. Muhammad. With other eye, maybe we will do inferior rectus recession.
Yeah.
No.
I'm not sure,
Because
actually.
here the problem it's not about the vertical misalignment, it's about the excyclotorsion. Here, Harada Ito procedure is very nice. It's a procedure that will strengthening the anterior fibers of the superior oblique.
Okay.
Harada Ito procedure. Here it's a strengthening of anterior fibers of superior oblique because of the anterior fibers of superior oblique is responsible for encyclotorsion. So if you strengthening the anterior fibers of superior oblique, you will treat the excyclotorsion here.
Yes, by increasing the encyclotorsion, the opposite in the opposite
You're talking
way.
about Faden's surgery, is it? The anterior lateral fibers of the superior oblique. Is that what the certain name of the surgery you talk about? Faden's, okay.
Harada Ito procedure.
Okay, Harada Ito. Okay, Harada Ito. Okay, right. Okay.
Yes. Okay, the last case here, the last pictures today. Dr. Muhammad, you want to make the comment directly to this patient?
Okay. This patient came to our clinic because of since birth, right head tilt. This is not the presentation of the patient. No. Please, the not the this is after correction of the head. Please, the not no, the first one in the right. In the screen.
This is the
Please
first
all
one.
the photos.
Yes.
Dr. Mohammed, I have a doubt. How would you clinically see because the entire
Yes.
the entire eye is white. I can't see any congenital vessel. How do you say it's excyclorotation just looking at the head? I mean, apart from the head tilt, what is the clue?
Again, you mean excyclotorsion by
Yes, yeah.
by indirect ophthalmoscope.
Or you do look for the fundus torsion. You look for the superior pole and inferior pole, how they have deviated, right?
Again,
as
The
we
fundus
show in
torsion.
this picture, Dr. Samuel, he look at the fundus photo.
yes.
Yes. So he can know it's excyclotorsion. And
Okay.
I mentioned
The
in the
fundus.
first the double maddox rod, you will see this this two lines. Here,
Yes,
but
double
we
maddox
don't
rod. Yes.
we don't have double
Yeah.
maddox rod. We use the fundus photo by
Torsion, fundus torsion picture.
ophthalmoscope. Yes.
yes, I told you if you want to go for exam, you can do double maddox rod, or you just buy the fundus picture, so you can know the excyclotorsion or cyclotorsion.
Yes.
Okay.
Yes,
Otherwise,
doctor.
apart from those two, there's no other way of finding out. Apart from those two methods, there's no other way to find out excyclorotation.
Yes. Yes.
Okay.
So
Yes.
this patient, I think he was 6 years of age, old of age, came to our clinic by this picture, right head tilt. Okay, the next photo, please.
Okay, you told him to look to the right side here?
No, not this is the next photo. The next photo beside yes, this is.
Yes.
Yes. After correction by my hand for his head, you can see facial asymmetry. Please, Dr. Abdulrahman, make a vertical line. Here you can see a smaller field right for this patient and a wider field left of this patient. Okay, the next photo.
Okay.
If you can choose the primary position, please. Primary position. Okay. This is not the primary position.
Right, left. There is no picture with the primary position.
No. We have.
1, 2,
yes,
3.
this is yes, this is the primary position. We can see here left over right. I think it was like 10 prism diopter. Okay.
Yes.
Here the left over right corrected on the left gaze. Okay. But here it's much more than in the primary position. I think it was like 20 left over right on the right head gaze.
Worse on opposite gaze.
Yes, book worse on opposite gaze. Here it's clear. Okay. Then this one.
Here left head tilt. Yes, it was like 16.
Worse on ipsilateral tilt.
Yes.
Better on opposite tilt.
It was like 16 prism diopter. It works, of course. But here on the right head tilt, the misalignment disappeared. Ortho here. Ortho.
Yes. You can see even the reflex here. It's central.
Yeah.
Boot better in opposite tilt.
Yeah.
Yes.
Correct.
Yes, Dr. Mohammed. And here?
The up gaze, okay, so it's somewhat, he has a V pattern. Okay.
Yes.
When comparing the up gaze and down gaze, it's about less than 15 prism diopter. Okay, but it's like V pattern. Okay, so the excyclotorsion here, the indirect ophthalmoscope check both eyes, and the excyclotorsion more than 10 degrees in the left eye, the patient planned for left inferior oblique myectomy. And inshallah, when the result captured, I will share it to this group, inshallah.
Yes, here inferior oblique overaction, how much, Dr. Muhammad?
Plus 3.
Plus 3.
Yes.
Okay. Yes. Anyone have any question, any comments, anything to add, please?
Do you have any pictures of skew deviation? And
We,
Dr. Ahmed, one request. There's you told about a 5-step skew deviation, right? Apart from Bielchowski head tilt test. Could you add those points also if you have certain notes on that?
Actually, skew deviation, we have a lecture, total lecture, Dr. Samuel, about
Okay.
skew
Then
deviation.
it's fine. Then it's fine.
So
Okay. Okay. Right.
let us discuss each topic in its lecture. Much
Okay.
better.
It's a separate topic. Okay. Okay. No
Yeah,
problem.
separate topic.
Sure.
Any other
Sure.
question according to fourth-year palsy?
Because you touched upon it, that's why I was curious. That's
Yeah.
why.
Okay.
Okay.
Thank you, Dr. Samuel. I will stop recording now.